Fanconi anemia is the most frequent inherited predisposition to bone marrow failure. There are other genetic predispositions. For bone marrow failure, they are quite rare, but for myelodysplastic syndrome, one is very common is DDX41 predisposition. And there are some other which are more rare, like ERCC6 L2 predisposition or Ligas4. There are other diseases. So probably each of them will require dedicated monitoring because the transformation is not at the same age. For instance, in Fanconi anemia, the transformation occurs at between 12 years old or to 25, let's say, okay, adolescent and young adults. In DDX41, it occurs later in life, after 50, 60 years old. For GATA2, it is 20 or so, and so on. You know. So first of all, we have to adapt the timing of the monitoring, and then the transforming events are not the same. So how to follow up those patients? The most obvious way would be to sample the bone marrow every year. It might be a bit too much, you know, for lifelong. So if we can precise risk factors, we should be able to focus on certain time. For example, in Fanconi, when they are the 1Q, then you can monitor more closely. In other disease, you can monitor depending of the mutation and so on. So for Fanconi anemia, we have to monitor copy number abnormalities, which is not easy. It's not a NGS if you want to be sensitive. This is why we try to develop a single cell analysis. For other diseases like RUNX1, for example, you can follow the second allele of RUNX1, the mutation of the second allele. So I will not go into details for each of them, but we have to develop tools and recommendation and probably consensual guidelines for each of the disease and in an international way probably, because these are rare diseases, so we have to put all them together to have more patients and to check at posteriori by evidence-based medicine that the recommendation we have set up are useful for the patient on the long term, I would say.